Take it away.
Hey, good morning. My name is Dr. Rachel Lee. I'm an associate professor in the Division of Infectious Diseases at the University of Alabama at Birmingham. Today I'm going to be talking about optimal duration and route and treatment for common infections. I have no financial relationships. So here are the objectives of our talk. So number one, we want to discuss how dogma in healthcare affects patient care. Number two, outline how dogma has changed around certain infections with oral versus IV therapy. I'll review the updated evidence around oral versus IV antibiotics for infections and highlight the risks to each of those. And then lastly, I'll kind of change a little bit and talk about how shorter courses of antibiotics are better for optimal duration and treatment of common infections. So I always like to start with a case. This is actually a case of a patient of mine. It's a 67-year-old gentleman with diabetes, hypertension. He presented with fevers, chills, malaise, and confusion. He's admitted to the intensive care unit where he's found to have vancomycin and cefepime are initiated, blood cultures are obtained, and they grow methicillin-sensitive Staphylococcus aureus. Infectious diseases is consulted, antibiotics are narrowed to cefazolin based on those culture results. And then physical exam reveals a necrotic fifth toe and a swollen knee at his former prosthetic joint. So during his hospitalization, he gets the standard workup by infectious diseases, which includes a TEE, that is negative for vegetation. His toe is surgically amputated and he has clean negative margins. He undergoes a washout of his knee and a stage 1 spacer is placed. His culture is clear after his knee washout, but he does have about 7 days of bacteremia. So the questions I hope to answer with this case through this talk are, number one, what is the appropriate antibiotic choice for this patient? And number two, what is the appropriate antibiotic duration? So how did we get here? I really think it's important to talk about dogma in medicine and why we do the things that we do. If we think about antibiotics, they truly were a wonder drug. In 1900, the top 3 leading causes of death were infectious diseases, includes pneumonia, tuberculosis, and acute diarrheal infections. In World War I, there were actually more deaths from infections than from battle wounds themselves. And so in 1929, Fleming identifies penicillin. And then in 1935, we had sulfonamides that were used to systemically treat bacterial infections. And so when World War II came around, this really truly was a wonder drug. So you can see some of the propaganda that was around penicillin, saved soldiers' lives, a race against death. Thanks to penicillin, he will come home. So all of this is truly just highlighting kind of the miracle of antibiotics, particularly during World War II. So we know that the availability of antimicrobial agents really predated the use of our randomized controlled trials that we use now to establish safety, efficacy, duration, and dose. And antimicrobials were just far more effective at reducing death from disease than virtually any other therapy. So you can think about how if you have nothing and then you go to something, how that really truly changes how we treat patients with infections. And then, of course, there are these strong antidote set of lives that are saved that can lead to dogma. And the word dogma comes from the Greek word that which one thinks is true. So that we had these celebrity stories at the time. So President Roosevelt's son was treated with sulfonamides because he had a severe streptococcus pharyngitis, unlike President Coolidge's son who died from a staphylococcal infection. And then we have these patient anecdotes. So as physicians and as clinicians, we have all of these cases that we are reminded of that really truly lead to us wanting to continue to use the same therapy. So let's talk about oral versus IV antibiotics, and particularly why we choose IV versus oral antibiotics or vice versa. I think it's helpful to frame this talk from this quote from Dr. Davar, who said, "No prospective study has really ever established IV antimicrobial therapy as a more effective than oral therapy for bacteremia, endocarditis, and osteomyelitis." So if we take kind of a case study around osteomyelitis and why we were using IV antimicrobials, you can look at this 1970 Waldvogel Sentinel study. It really is a Sentinel study because it helped establish clear definitions for osteomyelitis. It summarized the pathophysiology, and then it defined intensive treatment as parenteral administration of appropriate antibiotic at high dosage for 4 weeks. And so in their conclusion, they say, in our experience, osteomyelitis is rarely controlled without the combination of careful, complete surgical debridement and prolonged, meaning 4 to 6 weeks, of parenteral antibiotics at high dosages. If you look at this table on table 2, you can see that overall infection controlled with intensive treatment was 26 cases, and then failure with intensive treatment was only 1 case. So they really used that to establish the need for parenteral antibiotics. So when we think about these different studies, and I'm sorry that this didn't pop up in the right way, so you can see here there were case studies of endocarditis in terms of the 1940s and 1950s. So we first started with our sulfa drugs. In 1943, there was a pre-post study that found 99% mortality rate in nearly 2,600 patients with sulfa drugs versus 96 mortality rate in patients that didn't receive anything. So you can see how there was some establishment of that maybe these antibiotics are better than nothing at all. But then when you added in the penicillin cure rate, that really changed the cure rate from that 96, 99% down to 1%. And so that's really significant improvement there. And then with the tetracyclines and macrolides, you can see that that cure rate was kind of hit or miss depending on that. And so one of the quotes here that you can't really see in this disease, pretty much he said that oral administration is really highly variable, and with this we would recommend parenteral antibiotics. And so with that, that pretty much just shut the door on giving antimicrobial therapy. So let's dig a little bit deeper in understanding what is truly the issue of oral antibiotics and IV antimicrobial, and is there truly a difference in these antibiotic levels administered via the oral route. So this table kind of shows you these peak blood levels versus the minimum inhibitory concentration that's achieved by antibiotics to treat endocarditis. And so these are different published studies that are looking at that. So in the first column, you can see the oral drugs, these different antimicrobial antibiotics with peak blood levels. You can see what levels that they're obtaining, and then the MIC, and then what level is occurring with the peak blood level to MIC ratio. And so if you have an MIC ratio of less than or equal to 1, those typically do not work nearly as well. They're not overcoming that minimum inhibitory concentration. Whereas those antibiotics with peak levels that are greater than 1 can really establish treatment, effective treatment and therapy. And so this is not surprising. This goes along with those observational trials that were showing that tetracycline and sulfonamide and erythromycin really don't get high enough in the bloodstream to overcome infection related to endocarditis. Whereas these other antibiotics that we typically treat with, like penicillins and levofloxacin, moxifloxacin, trimethoprim, sulfamethoxazole, all do achieve that threshold. And what I like to tell residents and fellows that I'm working with is that bacteria really do not care about the route of antibiotics that are administered to the patient that they are infecting, only if the concentration of the antibiotic that arrives at the site of infection and whether or not that concentration is sufficient to kill them. So we who give antibiotics need to know the optimal amount and dose and duration in order to overcome that infection. So let's talk through some of these Sentinel randomized controlled trials that have recently come out comparing oral versus IV antibiotics. And so the first one is the OVIVA trial. This stands oral versus IV antibiotics for osteomyelitis. And so what this one did was compared standard IV therapy to standard oral therapy for bone and joint infections. It included people with prosthetic joints, hardware, vertebral osteomyelitis. Not every patient had debridement, and their primary outcome was treatment failure within 1 year. It was a multi-site study. It had over 1,000 patients enrolled, and actually most of the patients did have Staphylococcus aureus, but this was done in Europe, and so there were only 19 patients in here that had MRSA. And so if you look at this figure below, the intention to treat population and the pre-protocol population, so in all of these different, there was no difference between oral antibiotics and IV antibiotics. And I really do think that this was a Sentinel study because this is when, in the infectious diseases community, we really started talking about, can we do oral therapy consistently for treating this infection? Some of the other secondary endpoints that they identified was, if you kind of look through this, number one, antibiotic-related serious adverse events. There was more cases in the oral, in the IV group compared to the oral group, so 4.5 versus 2.2. And then these secondary endpoints in the second part below, it says IV catheter complication. Of course, that was much higher in the patients that had an IV and went home with that IV. So if you go to this website, it's bradspellberg.com/oral antibiotics. He has all of the papers in there that really kind of describe all the differences here. And even papers dating back to 1987 that compared these different regimens and the success related to them. And you can see out of 10 randomized controlled trials, over 1,600 patients, and really similar efficacy between oral antibiotics versus IV antibiotics, so 81% versus 80%. So if we look at another sentinel randomized controlled trial in oral versus IV, this is the POET trial that also came out in 2019 in the New England Journal of Medicine, and this stands for partial oral therapy for endocarditis treatment. This was 400 patients that had left-sided endocarditis. It was caused by either Streptococcus, Enterococcus faecalis, Staphylococcus aureus, or coagulase negative staph. So once again, this is a European study and unfortunately doesn't have really any cases of MRSA. IV antibiotics were administered for 10 days at a minimum, and then patients were randomized to oral versus IV therapy, and the primary outcome was a composite of all-cause mortality, unplanned cardiac surgery, embolic events, or relapse of bacteremia. And so if you look at the graph, so first is that Cox hazard model, the probability of the primary outcome of that composite score. And you can see that actually oral therapy was slightly better compared to IV therapy in terms of having less all-cause mortality, unplanned cardiac surgery, et cetera. If we kind of tease out the different primary endpoints, you can see the differences between the IV therapy and the oral therapy. So really no difference in embolic event or relapse of positive blood cultures, which I think is helpful for us when we're giving these medications. And then all-cause mortality, for some reason, was slightly higher in the IV treatment group. Now, since that time, you can see that there have been more people that have looked into the literature to identify whether or not there are other studies that are looking at oral versus IV therapy. The one that we just mentioned was that Iverson-Bungard study in 2019, but there was also another one that had 341 patients that looked at trimethoprim sulfamethoxazole, or Bactrim, plus clindamycin for, versus standard IV for Staphylococcus. So really this is 3 randomized controlled trials plus 1 quasi-experimental study, about 864 patients, and overall a similar success rate, 78% versus 68%. So the third trial here that I want to highlight that's really a sentinel randomized controlled trial in oral versus IV is the Sabato trial. This one actually came out in 2024. I wish I could remember what Sabato stand for. I think it's Staph aureus bacteremia, and then ATO, whatever that is. And so you can look at the open label non-inferiority randomized controlled trial. 31 hospitals, again, this is outside of the United States. And it looked at patients with Staph aureus bacteremia that were defined as having low-risk bacteremia, and they were randomized after 5 to 7 days of IV therapy to oral antimicrobial therapy. Now, you can see that they actually had a lot of difficulty identifying patients that were considered low risk. They had very stringent criteria to define that. So it was a very slow trial, and then of course COVID happened, and so it took a long time to get these patients. So they actually ended the trial before they reached their study population size. And so the primary endpoint here is any complication related to Staph aureus bacteremia within 90 days, and that included relapse, deep-seated infection, and death. And overall, the results showed that oral switch was non-inferior to patients with low-risk Staphylococcus aureus bloodstream infection. So really some kind of continued data that really supports the use of oral antibiotics. I think we as clinicians are very cautious with Staph aureus bacteremia. And so we have to be very careful with that. But this is a trial that really highlights that if you identify the right patient, you should feel confident in treating that with oral therapy. Now, once again, if you go to that Brad Spellberg site, he has kind of teased out oral versus IV antibiotics and bacteremia. And I highlighted here, the red is gram-negative bacteremia, and then the purple are gram-positive cocci. And there are really just a fair amount of studies, 11 randomized controlled trials, over 1,000 patients, similar efficacy, 81% versus 79% success rate for these randomized controlled trials. So now that we've kind of highlighted that we have opportunity to give these different oral medications, let's talk about shorter course antibiotics and some of the dogma related to that. So if you think about dogma for the duration of antimicrobial therapy, in the year 321, Constantine the Great declared that there'd be 7 days in a week. And our durations of antimicrobial therapy tend to follow this, 7 to 14 days for pneumonia, or 6 weeks for osteomyelitis or endocarditis. We tend to think that people can think better in those Constantine units, and so that's why we tend to give that. So early in the 1940s, physicians would treat pneumonia actually with penicillin based on response for 4 to 5 days, and then we had this kind of change to having longer duration, and that happened around 1945 when this person, Meads, administered antibiotics for pneumonia until there was a definite clinical improvement and the temperature had remained below 100 degrees for 12 hours, and then we give additional antibiotics for 2 to 3 days. So all those signs of clinical stability, but then out of concern for developing resistance or failure, we give 2 or 3 more days. So how many trials are needed to change the dogma surrounding shorter course antibiotics for common infections? I put this picture of a dog here because as I was creating this talk and I kept saying dogma, now the AI generated slides kept giving me a picture of a dog, so I thought that was funny. But if you once again go to Brad Spellberg's site, it has shorter is better. So he has looked at oral antibiotics, but he's also looked at optimal duration of antimicrobials. And he has highlighted 23 conditions with over 140 randomized controlled trials. And the results are equal. You can see community-acquired pneumonia, 3 to 5 days versus 5 to 7 days, and even things like neutropenic fever and how many randomized controlled trials there are. So in the next few slides, I want to highlight some of the more sentinel studies around optimal duration of antibiotics. How do we define appropriate antibiotic use? That's prescribing the right antibiotic at the right dose for the right duration for a specific condition. So some examples of inappropriate use is if we gave nitrofurantoin for pneumonia. Obviously that does not penetrate the lungs appropriately for treating infections. Clindamycin, 150 milligrams oral twice a day for skin and soft tissue infection. Well, clindamycin is the appropriate drug for that condition, but that dose is too low. It's too low of a dose and too infrequent of how many times we give it to the patient. And then lastly, azithromycin for 14 days for pneumonia. That's actually too long. It's the appropriate medication for the appropriate infection, but the duration is way too long. I was really lucky to work with the ACP to kind of identify some of the data about appropriate use of short course antibiotics for common infections. And so this paper really highlights 5 different infections and we'll kind of go through a little bit of the data here. So here's your summary. So acute bronchitis, which is something that a lot of our clinicians frequently see. In patients with COPD, based on the GOLD guidelines, clinicians should really limit antibiotic treatment duration to 5 days for patients with COPD exacerbations and have acute uncomplicated bronchitis who have signs of a bacterial infection. For community-acquired pneumonia, we'll go through this a little bit. These are patients who are not immunocompromised. You should give it for 5 days and ensure that patients are meeting signs of clinical stability. Urinary tract infections, similarly in women with uncomplicated cystitis, you should prescribe a shorter course antibiotic. And then with pyelonephritis, you should do 5 to 7 days with fluoroquinolones, and then with trimethoprim sulfamethoxazole, it's really going to be 14 days. And then finally, non-purulent cellulitis in patients with that non-purulence, really 5 to 6 day course that have antibiotics that are active against streptococci. So let's dig into the data a little bit more based on what came out of this table. So we know how to define community-acquired pneumonia. It's an infection in one or more of the lungs. It can be caused by bacteria, virus, fungi. We have those classic symptoms that are fever, productive cough with purulent sputum, dyspnea, pleuritic chest pain, and they're frequently diagnosed with a radiograph. This picture on the right is showing a right lower lobe pneumonia. The common pathogens here are Streptococcus pneumoniae, Haemophilus influenza, Mycoplasma pneumoniae, and Chlamydia pneumoniae, as well as Moraxella. That's also known as walking pneumonia. And so many times when you look at the definitions based on clinical guidelines, this excludes patients who are immunocompromised or develop pneumonia while hospitalized or on the ventilator. So there have been some meta-analyses that have looked at appropriate duration of antimicrobial therapy for pneumonia, and many of these are guided by validated measures of clinical stability. So if your vital signs return back to normal, you're able to eat, and you have normal mentation, and they typically say no less than 5 days of treatment. Now, when you compare the shorter course versus the longer course, there's really no difference between the two based on these meta-analyses of over, I believe this is 1,500 patients. But can we drive the needle further? So looking at 5 days versus 3 days of antibiotics. This is a Lancet trial that had non-inferiority randomized control trial of patients with moderate to severe community-acquired pneumonia who were given either 3 days of a beta-lactam versus 8 days. And the primary outcome was cure at day 15. And all patients had to meet that clinical stability that we've already described. So they looked at 300 patients and really overall similar rates of cure, 68% versus 68%. They even went so far as to look at kind of some secondary outcomes, which wasn't powered to do that, but when you look at just the different groups, there was really no difference between older adults or patients that had a higher PSI score. There was no difference between the two as long as they met that clinical stability at day 3. I've been able to do this for a few of my patients that met that clinical stability, and so far they have done well. I think we are very careful with which patients we define as meeting clinical stability. The next group that we looked at was urinary tract infections, and I think it's helpful to kind of describe all the different terms that go around there. So bacteriuria is bacteria in the urine. You don't typically have signs or symptoms of infection. Asymptomatic means that presence of bacteria without those signs and symptoms of UTI. And then a urinary tract infection can be anything. Infection of the bladder, the urethra, the ureter, the kidneys, or all of the above. I think it's more helpful to define it based on location. So cystitis is kind of a lower tract urinary tract infection, really around the bladder mucosa, whereas pyelonephritis is that upper tract and more into the kidneys. Some papers have defined complicated and uncomplicated. I think the literature is trying to change this to really get more of a standardized definition. So uncomplicated is UTI without compromise of the urinary tract, whereas complicated could be a UTI, but then you also have factors related to host defense, maybe obstruction like a prostate cancer, urinary retention, maybe you're immunocompromised in some sort of way, and structural abnormalities. Complicated also used to mean if you are a male that has a UTI, but I think that is also changing. What is the current data for UTI for treatment durations? Well, its appropriate diagnosis is important for the duration. Asymptomatic bacteria should not be treated except in very rare circumstances like pregnancy. If you have a symptomatic urinary tract infection that's uncomplicated, you should have it prescribed really focusing on treating E. coli. So that's going to be nitrofurantoin, which is typically 5 days, trimethoprim sulfamethoxazole, which is 3 days. Fluoroquinolines can also be used, and that's 3 days. I tend to reserve that for pyelonephritis, so I will try to use some of these other medications if possible. And then oral fosfomycin as a single dose. I've been able to give some patients oral fosfomycin. Some of our pharmacies, at least around here in Alabama, don't carry this, so you have to be a little bit careful with that one. Now, if you have more of a complicated urinary tract infection with acute pyelonephritis, the fluoroquinoline dose is going to be 5 to 7 days. And then dose-optimized beta-lactams are going to be 7 days, and trimethoprim sulfamethoxazole is 14 days, really because they haven't had enough studies to support the use of 7 days in trimethoprim sulfamethoxazole. So now that we know kind of what's been established, can we drive that needle further in pyelonephritis? So can we do 5 days for acute uncomplicated pyelonephritis? The answer, yes, we can. In this study, in women with pyelonephritis, cure rates with fluoroquinolones, which is really good medication for pyelonephritis, was 93% in 5 days versus 95% at 10 days. So really strong data to support that in a randomized controlled trial. In another study of 1,100 patients with complicated urinary tract infection, eradication rates of fluoroquinolones was at 88% at 5 days versus 86% at 10 days. Now, eradication rates means that they checked urine cultures at the end of therapy, which we do not do clinically, but that's typically done in a lot of these randomized controlled trials. The next question is 7 days the right amount for receiving trimethoprim sulfamethoxazole? And so this was a multi-center trial. It's only 81 women who received 7 days of therapy compared to 191 that received 7 days of ciprofloxacin, and they found likelihood of recurrent UTI at 30 days for both of those drugs was similar. And then lastly, is short course antibiotic appropriate for men with a urinary tract infection? And this was a study that looked at over 270 men with symptomatic UTI, and they were treated either with Cipro or Bactrim, and found that they had 93% resolution of symptoms in the 7-day group versus 90% in the 14-day group. All of these studies established that the susceptibility to these antibiotics was the appropriate for the treatment that they were on. Okay, so blasting through and moving on to skin and soft tissue infections. This is looking at shorter course therapy for antibiotics for cellulitis, typically non-purulent cellulitis. The study on the left was looking at a randomized controlled trial of 666 patients that were treated either with linezolid for 10 days or tadalafil for 6 days, which is a very similar medication to linezolid except it's a once-a-day medicine, and really found similar early clinical response in both of those groups. In the second group, this is the DANCE trial that was also done in Europe, and so it was 6 versus 12 days of flucloxacillin, which we don't typically give here in the United States. And they found similar rates of cure for primary outcome, and the non-inferiority couldn't really be called because they had these huge wide confidence intervals. I think there's been a lot of criticism of this study because flucloxacillin is not like a common drug that we typically give for cellulitis. It has some variable dosing issues and depending on the weight of patients. So there's a lot out there, but at least it's one that found really similar rates of cure overall. So as another kind of big group that we typically see here, especially in the South, is diabetic foot osteomyelitis. This is an interesting study because while it's small, they took 93 patients and they randomized either to 3 weeks of antibiotics versus 6 weeks. All of these patients received some sort of surgical debridement. And remission occurred at very similar rates in both of the groups, 84% versus 73%, with no differences in adverse events. The authors tried to do a multivariate analysis of clinical remission and found really no difference between the two groups. Overall, IV didn't show any sort of improvement in clinical remission or partial amputations or things like that. Now, there are some caveats for shorter duration of antimicrobial therapy. This is a study that looked at 6 versus 12 weeks for prosthetic joint infections. So this is an open label randomized controlled trial. 410 patients, these were all patients from France that had confirmed prosthetic joint infection, and they received either 6 weeks of antibiotics versus 12 weeks of antibiotics. Interestingly, they all received oral therapy, which kind of goes along with the earlier part of our discussion. They looked at persistent infection within 2 years, and you can see that 18% in the 6-week group compared to 9% in the 12-week group. And so because of this, in patients with confirmed prosthetic joint infection managed with surgery, 6 weeks of antibiotic therapy was not non-inferior to 12 weeks. So really this says that we should actually try to use longer courses in these patients with prosthetic joint infection. So moving on, let's talk a little bit about bacteremia. This is the BALANCE trial that just came out in New England Journal in 2024. Over 3,600 patients with bacteremia. Of course, they excluded Staphylococcus aureus, and they were randomized either 7 days versus 14 days of therapy. Primary outcome was death caused by, from any cause by 90 days after diagnosis. And they found that there was really overall no difference, 14.5% versus 16%. But there's a lot of limitations with the study. In the 7-day group, about a quarter of these patients received antibiotics for longer than 7 days. The vast majority of these cases were monomicrobial gram-negative, which makes sense. Like we feel pretty confident about 7-day courses in patients with gram-negative infections. Only 17% were monomicrobial gram-positive infections, and these were classically like 1 of 4 coagulase-negative staph or 1 of 4 Enterococcus faecalis, and about 12% of these were polymicrobial. So I know I've been talking a lot about shorter duration or optimal duration of therapy. I think it's important to point out that excessive antibiotic treatment duration can lead to kind of issues and increase the risk of odds of antibiotic-associated events. This was a study looking at all the hospitals in Michigan. There's a Michigan consortium, and these were patients that were discharged from the hospital with the definition of pneumonia. And by far and away, most patients had excessive treatment over that 5-day mark. And typically it happened to be either if you had a culture that was positive, so when we see something that's positive, we tend to want to treat it for longer, or that we would give a longer duration after the patient was discharged in hopes that they don't come back to the hospital, don't have readmission events. But we do know that that increase every single day increases the odds of having some sort of antibiotic-associated event. So you may be asking yourself, is there truly harm with extending antibiotic therapy by 1 to 2 weeks? And it's really, really difficult to kind of tease that out and determine that. There have been some meta-analyses that have tried to assess this. So there was one that looked at 71 randomized controlled trials, that's 23,000 patients, and looked at the harm with longer durations of antibiotic therapy. So antibiotic-associated harms occurred in almost 20% with adverse events. About 4.8% had superinfections and 10% had antibiotic resistance. And what they defined was that each day of antibiotic therapy was associated with a 4% increased odds of experiencing an adverse event, and this was significant. And so if you compared like 5 days versus 3 days, that's a 9% increased risk, but it was even higher if you compared 7 days to 3 days. Superinfection, which they typically defined as C. difficile, or antimicrobial resistance, which means maybe you become resistant to the antibiotic that you're on. Those were not significant, but it's just very difficult to kind of determine if those truly are related. I think C. diff, there are only 3 studies that evaluated for that, and if you're giving a shorter course of antibiotics, while it can happen, it doesn't typically happen as much as someone who's on it for a longer period of time. Now, in terms of antimicrobial resistance, this is a study of over 7,000 patients, had a discharge diagnosis of severe sepsis or septic shock, and they received at least 1 dose of cefepime, meropenem, or piperacillin tazobactam. The development of new resistance to any anti-Pseudomonal beta-lactam occurred at really greater than 3 days after the study entry. And so all 3 of these led to increasing resistance the longer that they're exposed to it. If you look on the outpatient side, which I think is a little bit easier for us to understand, this is a meta-analysis of 24 studies investigating if patients develop subsequent antibiotic resistance after receiving antibiotics in the primary care setting. And what they found was in urinary tract infections, which is something that we commonly see in the outpatient setting, your risk of developing resistance after getting antibiotics is 2.5. With respiratory infections, it's also 2.4, and the effect is greatest in the first month immediately after treatment. So with all of this in mind, I think it's helpful to kind of talk through some of the psychological insights into dogma and how we can kind of help shape other future clinicians in giving the appropriate therapy. So why do some clinicians want IV antibiotics even when informed of the updated data? And so we have something called cognitive biases. So a lot of times as clinicians, we have a bias for action, meaning I prefer to do something rather than just doing nothing. Or we can think about it as information neglect. The information about oral antibiotics was not relevant to my practice, so therefore I'm going to ignore it. You can think about social influences, what others do and what others want us to do. So for example, if everybody in your clinical practice gives IV antibiotics, it's very difficult to be the trendsetter and do oral antibiotics. Or if you have surgical colleagues want you to give IV antibiotics rather than oral antibiotics, that can also be difficult because you're receiving that influence. And then lastly, healthcare experiences, so trust. So maybe you're not fully trusting what I'm saying about oral antibiotics because of the history that you have. I once gave a patient oral antibiotics and they didn't do well. And so we have a lot of that frames how we do what we do in medicine. We know at least what has helped change and practice and make better antibiotic decisions. What has worked well is making those antibiotic harms personal and meaningful, at least in patient care, reporting positive antibiotic behaviors by others, and enhancing trust in data about antibiotics has worked for patients. But could we potentially apply this to clinicians and figure out if there's a way to improve that? What has not worked well is reframing choices involving antibiotics. So if you kind of change the numbers a little bit and say, give more of a positive framework rather than a negative framework, does that help? And it typically doesn't. And if you try to make antibiotic harms more relatable, so during COVID-19, Dr. Thorpe, who I worked with, tried to compare it to the harms related to COVID-19, and that really didn't work well, but it came out right around 2021 when people were really just tired of hearing COVID-19. So I've thrown a lot of information at you, so let's try to summarize this data related to the patient that I presented. So as a reminder, this is a 67-year-old gentleman who came in with methicillin-sensitive Staphylococcus aureus in his blood cultures. He was put on the appropriate antibiotics, found to have a necrotic fifth toe that was removed, and found to have a prosthetic joint infection in the knee. We have a lot of evidence that says that we've at least completely controlled the infection. So the first question is, what is the appropriate antibiotic choice for this patient? And so when we think about our IV versus oral therapy, it is reasonable to consider oral therapy in patients who have clinical stability, hemodynamic stability, the surgical or procedural source control has been achieved, there's no persistent bacteremia, patients able to absorb oral medications. I think about this a lot in my patients that have had a recent GI surgery and maybe they're on TPN. A published regimen is available with clinical outcomes data for that targeted pathogen, which we have in the case of methicillin-sensitive Staphylococcus aureus. And there are no psychosocial or logistic reasons for preferring IV. So in our patient, we can go through and the answer is yes, he's hemodynamically stable, we're done doing surgery, he's able to absorb his medicines, and we have published regimens that are available. So we have the OVIVA trial that included prosthetic joint infections, that DATIPO trial that was with the prosthetic joint infections published for oral regimens, and then we have data for dosing appropriately with MSSA bacteremia in the POET trial. Now to the second question, what is the appropriate duration of antibiotics in this patient? And the way that I apply data for the duration of therapy is, do we have a clear, defined source? Is the source controlled? Is there clear literature to support duration of therapy based on that source? And what is the appropriate follow-up to assess the patient's progress? So in this patient, we have a clearly defined source that's controlled. We had a surgery including putting a stage 1 spacer in. And there is a clear regimen for duration of therapy. The DATIPO trial really focused that antibiotic therapy for 6 weeks was not shown to be non-inferior to 12 weeks. So really we want to focus on that 12 week of therapy there. And then do we have appropriate follow-up? So the final decision for this person was oral cefadroxil plus rifampin for 12 weeks. And we had them have scheduled followed-up labs and follow up with us at 6 weeks. Now, I like to point out that we can convert data to action. There are tons of randomized controlled trials. Not everybody has the time to read over 26 randomized controlled trials on osteomyelitis or bacteremia or things like that. So we have been lucky to work with our antimicrobial stewardship team to develop these internal guidelines for doses of oral antibiotics for common infections. So for example, you have endocarditis for treating for methicillin-sensitive Staphylococcus aureus. They've gone through the literature and they've identified the appropriate dosing for these medications. So you can see amoxicillin and cefadroxil and linezolid. So it gives you a wide variety of options that you may have to change depending on your patient. As an example, here's bloodstream infection with Streptococcus pneumoniae. If it's penicillin susceptible, we would choose amoxicillin. If it's resistant, maybe we'll go to linezolid, et cetera. So I've really been happy and it's been great working with our ID pharmacists who are really truly smarter than me in terms of antibiotics to identify the best dosing based on the literature. Another way to convert data into action from appropriate duration of therapy are these antibiotics for pneumonia. So our antimicrobial stewardship team has kind of taken all of these studies that looked at appropriate duration of therapy and created these internal guidelines to kind of help guide our clinicians. Like, do we have a hospital-acquired pneumonia with a history of a drug-resistant infection? Then we would go for something like this. When can we use linezolid versus vancomycin, et cetera, and kind of the aspiration event and what we would typically do there. Now, having internal guidelines requires continual review of processes and assessment of new data. So if you develop this in your institution, really have a process in place to continue to review that. So with that being said, it's a lot of information, but I thank you for listening, and if you have any questions, please let me know. Okay, we are going to load the second talk, and we will get started in just a minute. All right. Hey, welcome everyone. My name is Dr. Rachel Lee. I'm an associate professor in the Department of Medicine, Division of Infectious Diseases at the University of Alabama at Birmingham. I will be discussing new drugs for resistant bugs and doing a case-based study for combating antimicrobial resistance. I have no relevant financial disclosures. My outline today is to really describe the burden of multi-drug resistant organisms globally and in the United States. We'll discuss misuse of antibiotics, including overprescription or incorrect duration, and if differences exist by race and gender. And then lastly, we'll go through kind of a case-based study of gram-positive and gram-negative bacteria and understanding the treatment of this. This is pretty high-level information, so hopefully you have pharmacists available at your institution Please, if you have questions with all of this, hopefully you can go back and look at the talk. I think it's very important to describe the epidemiology of multi-drug resistant organisms, because I know that clinically, if you care for patients in a hospital, you have seen these multi-drug resistant organisms. This is really an urgent global public health threat. It kills at least 1.27 million people worldwide, and it's associated with nearly 5 million deaths in 2019. That's pre-COVID. In the United States, more than 2.8 million antimicrobial resistant infections occur each year, and 35,000 deaths each year as well. That data is also from 2019. The cost associated with treatment infections caused by 6 of the antimicrobial resistant germs that we frequently see is is typically around $4.6 to $5 billion annually. Now, I like to kind of start with the kind of 30-foot view from the global burden of antimicrobial resistance. So this is data from 2019, and it looked across the globe, found over 4.95 million deaths associated with antimicrobial resistance. Death was highest in Western Sub-Saharan Africa, and the most common infection was lower respiratory infections or pneumonia. That happened in more than 1.5 million infections. There are 6 leading causes of pathogens that were associated with antimicrobial resistance: E. coli, Staphylococcus aureus, Klebsiella pneumoniae, Streptococcus pneumoniae, Acinetobacter, and Pseudomonas. And if you look at this graph here, you can see the pathogen attributable deaths on the y-axis, and then the different areas. So the first one is Central Europe, high income, and then Latin America, North Africa, South Asia. And so the pathogens have different colors here. So that orange one that you see is Staphylococcus aureus, and that by far and away happens in high-income countries more than other infections. Whereas the purple is E. coli. That's the most common in Central Europe and South Asia. But the numbers change, and the types of pathogens change as you get into different areas. So for instance, in Sub-Saharan Africa, that red column is your Klebsiella pneumoniae, and that's the most frequent cause there. Whereas in Southeast Asia, it's going to be something like Acinetobacter baumannii. So if you're working in these different areas, that's going to change your framework in terms of how you treat these infections. Now, what about antimicrobial resistance in the United States? This is the CDC 2019 Antimicrobial Resistance Threat Report. I think there is one that they're working on, hopefully will come out in the next couple of years. But you can see some of the data associated with these. So the top antimicrobial threats that they identified before COVID included carbapenem resistance Enterobacterales. This was 13,000 infections and about 1,100 deaths. Carbapenem-resistant Acinetobacter had fewer cases, 8,500, with 700 deaths, but much more expensive, and you can see that's probably due to the types of medications that we use there. Now, in 2019, drug-resistant Candida auris, there were only 323 clinical cases, but 90% were resistant to at least one antifungal medicine, and 30% were resistant to at least 2 antifungals. C. difficile, which is the infectious diarrhea that we typically see after giving antimicrobials, has by far and away some of the highest numbers, 223,000, with 12,000 deaths, and that has a very high rate of costs associated to healthcare, and that's $1 billion there. And then lastly, drug-resistant Neisseria gonorrhea is about 5,500 cases with 1.14 million deaths each year. So there is some good news that came out of the 2019 Antimicrobial Threat Report, is that prevention works. And so I work in infection prevention and as a healthcare epidemiologist. And so we know that there are randomized controlled trials that have shown a lot of things that we can do to help decrease these infections. So if we prevent device and procedure related infections, if we stop the spread of resistant bacteria within the healthcare facilities, which is why sometimes we recommend contact isolation gowns, if we can contain these emerging threats through early detection and response, which is some of the reasons why we may be doing swabbing for different drug-resistant infections, tracking and improving appropriate antibiotic use. This is where our antimicrobial stewardship teams come into play. And then infection prevention and control in non-hospital settings is key. So we know in nursing facilities or in congregate settings, we really want to do everything we can to prevent the spread of infections there. Now, when COVID-19 hit, we saw significant increases in our hospital-acquired infections and our multi-drug resistant organisms. So we just mentioned how controlling those hospital-acquired infections reduced the number of MDROs. Well, when this came into to play, we saw high increases in ventilator-associated pneumonia, high increases in our MRSA, and so really the multi-drug resistance increased about 20% and peaked in 2021. These numbers have come down significantly, but it took quite some time and remained above pre-pandemic levels for at least a couple of years. When we kind of break it down for the different rates, you can see here in 2019 compared to 2020, almost everything was significantly increased and then remained that high numbers. Even as late as 2022, we saw an increase in hospital onset CRE, carbapenem-resistant Acinetobacter. Our clinical cases of Candida auris have really skyrocketed across the United States, as well as some of our other drug-resistant organisms. So I love talking about transmission dynamics of multi-drug resistant organisms because ultimately it's really, really complicated. We know that any antibiotic use can lead to antibiotic resistance. We have these antibiotics and we give them in order to prevent infections like we talked about in the last talk. But unfortunately, the resistance traits that can be inherited from generation to generation of antibiotics. And so they can have plasmids or transposons or even viral phages that can lead to transmission of those mobile genetic elements that really help define that multi-drug resistant organisms. These bacteria, they are everywhere. We see them a lot in the hospital, but they can be outside of the hospital. We have the antibiotics, but then that can lead to antibiotic resistance. And we see a lot of travel globally, and that has led to the spread of these infections globally. Within hospitals, there are kind of two different hypotheses or models of how multi-drug resistance organisms are spread. So if you have your drug-resistant patient in the middle, the first model is that drug-resistant patient is shedding those drug-resistant organisms from the colonization and then fecal contamination to surfaces in the hospitals or shared instruments in patient rooms, and that leads to another transmission to another patient as that one leaves and another person comes into the room. The other model is that you have these multi-drug resistant organisms and they come from the microbial community and then they're persistently colonizing the hospital-built environment, and then that leads to colonization of the patient. And so really to understand the difference between these, researchers have to determine what are the hospital surfaces that are acting as reservoirs, what are the spatial and temporal dynamics of that reservoir colonization, are resistant strains colonizing the hospital-built environment also detecting from human clinical infections. So I'll talk about a few different cases as they relate to these different models. So model one, you have a colonized patient that colonizes the environment. This is an interesting case. This actually happened quite some time ago when carbapenem-resistant Enterobacterales was rare. And this happened in the NIH. So they had a patient in 2011. That first little line there that came in was known to be colonized with that bacteria. You can see they put them on appropriate isolation. They initially started in the intensive care unit, and then they went to the ward, and then they left. And then a couple of months later, they started finding carbapenem-resistant organisms, initially in that patient 2, and then followed by 3, 4, et cetera. Over the span of the next few months, they continue to have these positive patients over the period of time. And it was really difficult to determine where that was coming from. They finally did whole genome sequencing, and they found that yes, they were all related. And it went in a different direction than what you thought. So in that C diagram there, you can see patient 1, which was our index patient, actually had a direct transmission to patient 3. Which they weren't really thinking about, but it happened when they were both on the intensive care unit. And then patient 3 led to a whole bunch of patients getting colonized. And so there were multiple different transmission events that were very difficult to describe and to identify. And the only way that they were able to identify that is doing whole genome sequencing and seeing how these isolates were related to one another. Another way to think about the second model is whether or not colonization occurs in the hospital. Now, when we look at a standard hospital room, this is actually a hospital room at the UAB, there are multiple places that become colonized with bacteria. The door handle, the WOW, the IV pole, the main computers that are controlling the ventilator, et cetera, the patient bed table, maybe the bedside chair, all those places can really get colonized. So we have to have good processes in place in order to appropriate clean these areas. So this was a study that was actually done at the University of Michigan, and they did surveillance of the nose, the hand, and 6 high-touch environmental surfaces on days 3, 7, and then weekly thereafter. And so 14% of the patients were colonized with a drug-resistant organism at baseline. About 29% of the rooms actually had a drug-resistant organism at baseline as well. What they found was that each of these became more similar to one another the longer that a patient stayed in the room. So there was a 6% risk of newly acquired multi-drug resistant organisms on the hands during their stay. So that's 24.6 per 1,000 patient days. So unfortunately, we can see how being in the hospital puts people at risk for having that transient colonization. Okay, another way to look at that second model is looking at multi-drug resistant organisms and the hospital water environment. Over the last 20 years, we've really started to get more understanding of how dangerous the water in our healthcare system can be. There have been multiple reports of carbapenem-resistant organisms in the hospital water environment. And so there have been multiple studies that have looked at critically ill patients, immunocompromised patients, and they've tested the sink traps of the patient-specific sinks in those rooms, as well as to do whole genome sequencing of maybe the pathogen that a patient is growing, and they are related. Drains, sinks, faucets are frequently colonized, and there's really not a lot that we can do to control this outbreak, because once the water is contaminated, once that sink trap is contaminated, it's very, very difficult to eliminate it from the water environment. So we have to do everything we can to prevent splashes, and to remind our healthcare workers to be very careful with water when we're taking care of critically ill patients. This is an interesting study that looked at the reservoir colonization in a new hospital environment. So they started off with that purple area, the old ICU, and they looked at ICU surfaces and did surface samples in the new ICU every 2 weeks for 5 months, and then every month for 1 year. So they were swabbing all of these, and they were doing selective culture and then doing whole genome sequencing. And what they found was that everything started to lean. It started off with our typical kind of gram-positive, things that live on our skin, like staph, et cetera. And then as the water environment kind of developed, that's when we started seeing more Pseudomonas. And there were definitely some highly related Pseudomonas in these different environments as it became colonized in the ICU. It did not take very long for that period of time to happen. I think it was about 5 or 6 months. So with that being said, let's talk a little bit and do a little shift and discuss antibiotics and the development of multi-drug resistant organisms. Globally, antimicrobial consumption is accelerating, particularly in lower and middle income countries. The WHO has created this watch antibiotic to help understand like which antibiotic should we watch, which ones should we be aware of, which ones should people have access to. And overall, the watch antibiotics, the ones that we should be really careful with, have increased 90% worldwide. 165% increase in lower middle income countries between 2000 and 2015. When we think about outpatient prescriptions in the United States, at least 28% of our antibiotics prescribed in the outpatient setting are not needed. More than 60% of the antibiotic costs are associated with the outpatient setting, and with 80 to 90% of our human antibiotic use occurring there. So in 2023, which is the most recent data that we have from the CDC, providers prescribed 252 million prescriptions. And this heat map shows you that the darker color is the higher number of prescriptions per 1,000 people. On average, it was about 7.5 prescriptions for every 10 people, but you can see in the Southeast, we really have a higher use of antimicrobials here. We're in kind of, unfortunately, up to 1,200. So that means 1.2 prescriptions per person. So azithromycin, amoxicillin are the most prescribed. That makes me think more of these respiratory tract infections. And then outpatient prescriptions really truly vary by state, and they vary by the person prescribing them. They can vary by race. There's a lot to unpack here, but I think overall it just shows our kind of US uptake of outpatient antibiotic prescriptions. On the inpatient antibiotic use, this is also data from 2023. It's a little bit more difficult to kind of compare hospital to hospital. What the CDC has done is created this thing called a standardized antimicrobial administration ratio. And this is really a summary measure to compare antimicrobial use to hospital settings. So that compares your observed antibiotics compared to your predicted. Typically, we think anything that's greater than 1 means that you're doing more observed to what they think is predicted. And so in 2023, about 43% of the facilities that are giving this information had their all total antibiotics SAR greater than 1. So that means every single antibiotic that is on this list was more than observed compared to the predicted. I think there's a lot to unpack here. It's been a little bit difficult to use this on an individual hospital setting, but there are success stories on the CDC. So overall, you can see here, we can do things to help with resistance and related to some of the antimicrobials that we prescribed. This was a kind of a 10-year study that we looked at that compared before we had our antimicrobial stewardship team compared to after, when we started controlling the amount of fluoroquinolones. And what we found was that in all of the organisms, when we started controlling how many people could actually get that fluoroquinolone, we were able to improve the resistance related to those bacteria. And it took quite some time. Some of these it took like 5 or 6 years. If you think about the ones that we typically see in the hospital, and that includes Acinetobacter, Enterobacter, Klebsiella, Pseudomonas, all of these improved when we were kind of being very judicious with our fluoroquinolones. The one that didn't change very much is the one in the middle, the E. coli. So you can see that the resistance rate was overall about the same. What we did was slow kind of the progression over time, but we see a lot of E. coli that occurs in the outpatient setting. And so a lot of these were probably coming in from the community. So let's think a little bit about combating antibiotic resistance. In order to combat antimicrobial resistance, we need a few things. So number one, we have to track data. So if you don't know what's going on in your institution or in the community, it can be very difficult to create a plan to tackle it. Some of the examples that I can think of here, so Candida auris is one that has started to take hold in Alabama. And so being able to track patients that need that screening and track the data is difficult, especially if you're going to a new electronic medical record. We want to be able to do infection prevention containment, so all of our standard IP practices like washing your hands, following isolation guidelines, and then containing it. If we have a patient that is very drug resistant, we want to make sure we put them on the appropriate isolation. If we can improve antibiotic use across our institution, then that helps. And then if we improve vaccines, diagnostics, therapeutics, so if we have less people with those infections, we have better treatment options, then that should help combat antimicrobial resistance. So with the kind of the last few slides, we're going to really dig into the different treatment options for multi-drug resistant organisms. Hopefully I've established for you that we do have an MDRO problem here in the United States, but I think we have some different opportunities in order to give the right treatment up front. So as you can see from the CDC, every time that an antibiotic is approved or released, unfortunately, we identify resistant bacteria. So for instance, in the top, penicillin was released in 1941, and we developed penicillin-resistant Staph aureus in 1942. This data only goes through 2015, but that ceftazidime avibactam, which is really used for drug-resistant infections, was released in 2015, and in the very same year, we found drug resistance to that. we really had a period of time where we did not have any antimicrobials, and so that really led to some difficulty in terms of treating these drug-resistant infections. As of November 2021, there have been 80 products, 46 antibiotics, and 34 non-traditional antibacterial agents that were in clinical development, 3 of which were in the pre-registration phase. And of these traditional antibiotics, 28 were reported to be active against these WHO priority pathogens, 13% against TB and 5 against C. diff. Excuse me for a second. So the way that I like to think about antibiotics is thinking about where they work. I'm sorry, I'm going to cough again. Excuse me for a second. All right. So you can think about these different groups and where they act. I think it's helpful from a medical student perspective. This is all the classic things on step 1 where these different antimicrobials work. But what's more helpful is thinking about antimicrobial resistance. And there are 2 big buckets that you can think of. Intrinsic resistance is the ability of bacteria to resist the action of an antibiotic due to its structural or functional characteristics. For instance, we don't ever use vancomycin for gram-negative bacteria because the cell wall of the gram-negative bacteria makes it have intrinsic resistance to vancomycin. You can then acquire resistance, and there are a couple of different pathways. Number 1, the bacteria can create these efflux pumps and pump the antimicrobial out. So Pseudomonas is really good at doing that. Number 2 is that you can modify the antibiotic target through genetic mutation of the target. So this happens with daptomycin resistance in Enterococcus. This also happens, this is the pathway for vancomycin resistance in Staphylococcus aureus. And then lastly, you can have that inactivation of the antibiotic itself, so it gets into the cell, but then there are active enzymes that then break it up. And so this is a lot of what we're going to be talking about in the next part of this talk. So let's talk about gram-positive bacteria first. So you have a 67-year-old gentleman who's presenting with fever, cough, dyspnea on exertion over the span of 7 days. 10 days before admission, he has endoscopic retrograde cholangiopancreatography, or ERCP. On exam, he has a fever, his heart rate's 111, his blood pressure is 150 over 79. His respiratory rate is about 22 breaths per minute, and his oxygen level is low, it's 88% on room air. You hear a murmur at the apex and bilateral inspiratory crackles. His white count is elevated and his creatinine clearance is decreased, it's 45. You get 3 sets of blood cultures that were obtained in all isolated gram-positive cocci in chains that were identified as Enterococcus faecium. So what is the best empiric antibiotic choice? So with Enterococcus, depending on the species, empiric antibiotic choice can be quickly determined. And so Enterococci are important because of this inherent antibiotic resistance profiles that they have in certain species. So if you see Enterococcus faecalis, this actually has relatively low levels of antibiotic resistance. About 10% or so are vancomycin resistant, and that may depend, those numbers may differ depending on where you're located. So for instance, in one of the VA facilities that I work at, the antibiotic resistance to vancomycin is like 2%. So I feel pretty confident about the susceptibility to ampicillin based on that. 80% of E. faecium isolates are vancomycin resistant. And then there are 2 pathogens, Enterococcus castelliflavus and gallinarum, that are intrinsically resistant to vancomycin. So if you have a culture and it's growing E. faecium, E. castelliflavus, or E. gallinarum, you can pretty much assume vancomycin resistance, and you want to automatically prescribe antibiotics that would be better than vancomycin, so daptomycin or linezolid. So in this case, I would start either daptomycin or linezolid in this patient until we have more susceptibility. Okay, moving on, case 2. You have a 47-year-old female. She has breast cancer. She receives chemotherapy via right chest port. She has fevers and blood cultures, and she has methicillin-resistant Staphylococcus aureus. She is started on vancomycin, and then unfortunately her cultures remain positive October 1st, October 3rd, October 5th. The team removed support then, October 7th, and then October 9th. You get a vancomycin trough, and it is 12. So what's the next best step in treating this case? I think it's a good kind of chance to talk about pharmacokinetics and pharmacodynamics. And this is really in a nutshell. I'm obviously not a pharmacist. This is when I rely on my pharmacy colleagues to help keep me in line. But PK describes the time course of the serum level of antibiotics. And then PD, or pharmacodynamics, describes the relationship between the antibiotic concentration and the magnitude of killing. So we get that MIC number, the minimum inhibitory concentration, from the lab. That's determined by the bacteria. And so we have to know how much antibiotic is needed to really overcome that inhibitory concentration. We have drugs that we think about time over MIC, so it's the amount of time that the unbound drug concentration remains above the concentration. So time over MIC is going to be your beta-lactam antibiotics. Your concentration max over MIC is going to be the relationship between the maximum concentration of the drug and the MIC. So aminoglycosides are the ones that we classically think about here. And then there's one that kind of is, if you think about it, is both. Antimicrobial AUC to MIC, so area under the curve to the MIC. That's the ratio between the total area under the concentration curve over a 24-hour period and the MIC. And this is where vancomycin works. So we classically would get a vancomycin trough level at UAB, but the ASHP guidelines have actually recommended transitioning over to an AUC to MIC dosing, which you want to range around 400 to 600 for optimal dosing. These higher AUC to MIC ratios are associated with lower mortality, treatment failure rates, and what we have found is that targeting troughs of greater than 15 have been significantly associated with acute kidney injury. So when we've made our transition from this AUC to MIC from the trough, we've actually seen a significant improvement in our acute kidney injury related to vancomycin. This is data looking at treatment failure in patients with Staph aureus bacteremia. And so this one, is comparing if you have a trough level of greater than 15 compared to a trough level of less than 15. And there's really no difference in terms of treatment failure, 33% versus 38%. If you look at the AUC to MIC of greater than 400 to less than 400, then you start really seeing a huge difference in the treatment failure. And so this is one of the main reasons that we switched over to software that can help with this. Now, you may be asking, at what point do we start considering dual antimicrobial therapy for MRSA bacteremia? And so there was a JAMA study that looked at patients with methicillin-resistant Staphylococcus aureus, and does the addition of 7 days of an anti-staphylococcal beta-lactam in addition to standard therapy improve clinical outcomes at 90 days. This is a study that actually looked at starting that addition of a beta-lactam at the time of admission. So they did daptomycin and ceftaroline, or vancomycin plus ceftaroline, versus either vancomycin or daptomycin alone. And what they found, the primary outcome, there was no difference, 35% versus 39%. So this study said that no, you should not start the addition of a beta-lactam at the time of admission. But there is a role for dual antibiotics for persistent bacteremia, so positive cultures after 7 days of effective therapy. And while it may not help with mortality, it can help with length of stay, it can help with clearance of your blood cultures quickly. I'm currently on the infectious disease service, and we just recently changed the person to daptomycin and ceftaroline for this persistent bacteremia. So we're hoping that that will help while we continue to identify the source of the patient's infection. Now, we talked a little bit in the last talk about oral versus IV antibiotics for bacteremia. And so once again, Brad Spellberg, who is the Chief Medical Officer for LA County Hospital, has a really great website that goes through the oral antibiotics and the appropriate duration of therapy, so you can see that link for you there. Now, in terms of gram-negative bacteria, we talked a little bit about gram-negative bacteria before. This is the most common group of gram-negative pathogens that are encountered clinically, which is the Enterobacterales group. You can see all the different families of Enterobacterales, but classically we think of, E. coli and Proteus and Serratia, et cetera. Those are the common things that we see in the hospital. Each of these can potentially create beta-lactamases, and we'll go through some of these different Ambler classes that you can see here. So the Ambler classification really helps us determine what is the appropriate antibiotic for treating these patients. Ambler class A is going to be your CTXM or ESBL. It can also be that KPC, which is a carbapenem-resistant gene, resistance gene. And so if you have a system that can tell you like the TIM or SHV that confers resistance to Zosyn, which is potentially one of your main workhorse antibiotics that you see there. Ambler class B are the ones that I typically get concerned about. This is your New Delhi beta-lactamase or IMP, VIM. These are very drug-resistant genes and really resistant to a lot of carbapenems. Ambler class C is probably one of the more common ones that you see. This is our AMP-C. The way to think about it is HEC yes, which I'll talk about in just a minute. There's something called chromosomal inducible. So initially it may appear susceptible on your testing, and then you give something like ceftriaxone or ceftazidime, and then the patient improves a little bit, but then they get worse, and that's because you've induced that resistance. And then lastly is Ambler class D. Those are your OXA genes, and they have a different kind of expanded spectrum resistance to cephalosporins. And then the 23 is for sulbactam resistance. Now this seems probably a little bit nebulous right now, but hopefully as I go through some of these cases, it will make a little bit more sense. So all of these, once again, are very similar cases to what I've had on the infectious disease consult service. So you have a 72-year-old female. She comes in with dysuria, fever, she has CVA tenderness. Her vital signs are consistent with septic shock. You get blood and urine cultures that are obtained that show E. coli. And you can see the susceptibility, so it says it's piperacillin tazobactam sensitive, meropenem sensitive, but it's resistant to ceftriaxone and resistant to ceftazidime. What is the appropriate antibiotic choice for this patient's bacteremia? Well, this was actually answered by the Marino trial, which came out in 2018. And the question is, can piperacillin tazobactam be used as a carbapenem-sparing option to treat ceftriaxone-resistant E. coli and Klebsiella bacteremia? So similar to the case that we just described. This was multi-site study in multiple countries, and they compared 1-to-1. People got meropenem versus piperacillin tazobactam, and they looked at 30-day all-cause mortality. And what they found here is that 12% of people died in the piperacillin tazobactam group versus 3% in the meropenem group. And so what this study says is that if you have someone that has ceftriaxone resistance and it's E. coli or Klebsiella, you want to give meropenem unless you have other kind of oral options available that is not Zosyn. This is someone called Sarah Dong, and she's made a whole bunch of different handouts in terms of managing infections. I really like this one because it's easy to read. So this is looking at managing infections with ESBL producing organisms, which is what we described. Ceftriaxone resistance should be your clue here. So if you have, even if your lab doesn't say this is an ESBL organism, you can say, if it says ceftriaxone resistance, you can use that as a proxy. E. coli, Klebsiella oxytoca, those are the ones to look for. And so depending on the type of infection and the location of infection, that may change how you treat it. So your preferred agents for uncomplicated cystitis or pyelonephritis are going to be your non-beta-lactams. So you can think in cystitis, it can be nitrofurantoin if it says it's sensitive, Bactrim if it says it's sensitive, whereas in pyelonephritis, you would want to do something like ciprofloxacin or Bactrim if it says that it's sensitive. In your bloodstream infections, though, obviously we wouldn't want to use nitrofurantoin in the blood, so then you can think either ciprofloxacin or levofloxacin or trimethoprim sulfamethoxazole, or you can use your carbapenems if that's your go-to medication there, at least initially. Moving on to our next case, you have a 32-year-old male. He presents as a gunshot wound victim and is admitted to the trauma intensive care unit. He's placed on the ventilator on September 1st. On September 9th, he develops worsening oxygenation. His chest x-ray shows new worsening infiltrates. He's placed empirically on ceftriaxone. He initially improves. His cultures grow E. cloacae, and they're sensitive to ceftriaxone, cefepime, meropenem. 2 days, though, after starting that ceftriaxone, his oxygenation worsens. What is the next best step for treatment of this patient? So this is that Ambler class C that we were talking about, or AMP-C production. It really happens by Enterobacterales, and it's inducible chromosome resistance. So it appears, at least in the lab, that it's sensitive. Then you give the medication, specifically ceftriaxone, and then the patients do worse. The way to remember it is something called HEC-YES. So HEC-YES stands for Hafnia alveoli, Enterobacter cloacae, Citrobacter frundii, Klebsiella aerogenes, and Yersinia enterocolitica. Of these, I think the most common one that you're going to see is Enterobacter cloacae or Klebsiella aerogenes. The other ones, I don't think I've ever seen Hafnia, at least on the inpatient side, and I've definitely not seen Yersinia. But all of these pathogens can have this inducible resistance. So while it may say that it's ceftriaxone resistant, you really want to choose something like cefepime for treating this patient. So if you have these inducible AMP-C beta-lactamase producers, your therapeutic considerations, like we talked about, cefepime is really recommended. You can do carbapenem in some of these cases. If you have that uncomplicated cystitis, you really want to consider use of something like piperacillin, tazobactam, and then for your non-beta-lactam agents, same considerations here that we've talked about before with ESBL. If they're chromosomal de-repressed, that means that what it says on the susceptibility is what it is, so then you just treat according to those susceptibilities. Okay, moving on. So this is the next case that I had. I had a 57-year-old gentleman. He underwent living donor kidney transplantation on May 1st. He's discharged home, was doing well, but then 2 weeks later came in with fevers. His urine and blood cultures grow Klebsiella pneumoniae. And in our lab, we were actually able to identify the NDM gene. So what is the best drug for treatment? Carbapenem resistance Enterobacterales accounts for more than 13,000 hospital-acquired infections, many deaths annually. That's based on that CDC threat report that we talked about. And the carbapenem resistance is at least to one carbapenem or produces a carbapenemase gene. There are some that have some inherent resistance to imipenem, but most labs have already kind of teased all that stuff out for you, and then we'll present it to you so that you can help interpret it. If you look at the data over time, which is what this table is showing, 2019 is the blue, 2020 is that dark blue, and 2021 is the pink one. And you can see that carbapenem resistance rates have really increased from 2020 to 2021. There are multiple mechanisms of resistance, but they're divided into carbapenemase producing and carbapenemase non-producing. The carbapenemase producing ones, the most common ones are your KPCs, but we started seeing some of our more resistant ones like the NDM and the VIM and OXA kind of come up over the past couple of years. Excuse me for a second. So what do we do for treatment options for carbapenem resistance? So as you've kind of heard with some of these drug-resistant infections, if you have a urinary tract infection and it's showing susceptibility to some of these things outside of your beta-lactams like nitrofurantoin or trimethoprim sulfamethoxazole or your fluoroquinolines, go for those. Other considerations, you can actually give a single dose of aminoglycoside, which has really good results there. You can do oral fosfomycin if you have E. coli. And then we can kind of tease out some of these more advanced beta-lactams like ceftazidime, avibactam, or meropenem vabobactam, all of these other ones, even cefiderocol. Now, if it's non-carbapenemase producing outside of the urinary tract, then we can consider some extended infusion for meropenem. This is only able to be done if your lab is actually looking for those carbapenemase producers. So some people may not be able to have that, and you may not be able to do that. Excuse me. And then as you get more of these different resistance genes, you can see here the preferred treatment options. I will say that it is very confusing. Hopefully you have an infectious disease consult that you can reach out to, or you can reach to your pharmacist. But I do have a table at the end where you can kind of go through some of these. Now, in terms of carbapenem-resistant Enterobacterales, ECOMID is kind of the European guidance for these infectious diseases, and the IDSA is the Infectious Disease Society of America. And they break it down by these different types of infections located, whether or not they're severe or non-severe, combination therapy, and whether or not you can do carbapenem-based therapy. I just want to point out, if you have a severe infection outside of the urinary tract, that's when you really want to do ceftazidime, avibactam, or meropenem-vaborbactam. So you may be reaching out to your antimicrobial team to see if you have those medications on hand. All right, moving on to our next case. You have a 20-year-old male. He has been admitted for the past 3 months with a really bad burn, 90% total body surface area burns. He develops fevers. He has a worsening eschar on the burn on his hand. His blood cultures are obtained, and they reveal Pseudomonas aeruginosa, and it says that it's resistant to piperacillin tazobactam, ciprofloxacin, cefepime, and meropenem. Which of the following does not have activity against DTR, or difficult to treat resistant Pseudomonas? So we have different definitions for our drug-resistant Pseudomonas. Number one is MDR Pseudomonas, or multi-drug resistant Pseudomonas. That's when you have no resistance to at least one antibiotic in 3 classes where susceptibility is suspected. So if you have resistance to piperacillin tazobactam, ciprofloxacin, and cefepime, that would be 3 different classes. Now, the Pseudomonas aeruginosa with difficult to treat resistance means that they are resistant to all of the anti-pseudomonal beta-lactams and the fluoroquinolines. So you can see all the ones that are listed here. There are multiple resistance mechanisms that I won't really talk through, but there are a lot of different ones that Pseudomonas can do. And so if you have multi-drug resistant Pseudomonas aeruginosa, your traditional anti-pseudomonal beta-lactams are preferred here if it says that it's susceptible. So if you only have one of them resistant, but say the piperacillin tazobactam is susceptible, then go for that one. Your second choice therapy here is going to be carbapenems. And then third is fluoroquinolines if it's susceptible. In your difficult to treat Pseudomonas aeruginosa, which is the case that we presented, the ones that you think about are going to be ceftolozane tazobactam, ceftazidime avibactam, imipenem relebactam, and cefiderocol. Okay. Next case, this is a 47-year-old female. She came in for a spinal hardware infection. She's currently receiving vancomycin and ceftriaxone. Her course has been complicated by respiratory failure requiring tracheostomy. 2 weeks into her hospitalization, she developed signs of sepsis and worsening oxygenation. Blood and BAL cultures are growing Acinetobacter baumannii that is carbapenem resistant. So what is the appropriate initial antibiotic choice? Now, what we are talking about here is something called CRAB, which is carbapenem-resistant Acinetobacter baumannii. It's an opportunistic pathogen, so it loves to live in our hospitals. It can cause a variety of different infections. Typically, it doesn't respond to some of our standard antibiotics, which can be difficult. And it can create these enzymes that make it carbapenem-resistant. And these are going to be the OXA23 or OXA 2440-like. We've seen large outbreaks of carbapenem-resistant Acinetobacter in hospitals and nursing homes. There was a really large one that occurred in a COVID unit, which, if you think about patients that are at risk for pneumonia, that would be one of them. And so they produce these carbapenemases. So typically we think treating Acinetobacter with a sulbactam drug like Unicin, which has sulbactam in it. But with those OXA-producing ones can make it resistant to the sulbactams. So in terms of treatment options, we still want to try to get a sulbactam-containing agent. So sulbactam, durlobactam is a new one, plus carbapenem, either imipenem or meropenem, so you think dual antimicrobial therapy there. Or you could do a high-dose ampicillin sulbactam, which is Unicin, plus an additional agent that may be sensitive to on our susceptibilities. We do not recommend nebulized antibiotics because they're really lack of benefits and concerned for this unequal distribution in the lungs. So you may be treating the top part of the lungs, but it's not getting down to the lower part. And then it's also been shown to cause bronchoconstriction. All right, so I have thrown a whole bunch of different resistant mechanisms at you that can be very, very confusing. But I'm hoping that this table will really help you in terms of treating. So if you have ESBL, you can see green is good, and so we have a lot of different choices there. Carbapenems are going to be kind of your drug of choice if it's in the bloodstream, et cetera. If you have AMP-C production, you can think of multiple different kind of treatment options there, but I typically will do something like cefepime. And then for KPC, you can see that we start kind of losing some of our susceptibility as we go forward. The metallo-beta-lactamases, cefiderocol is your drug of choice here. And then for the OXA48, that's when you think ceftaz-avibactam or cefiderocol. I know you're probably looking at this table and you see the green line kind of across as cefiderocol, but you really want to be very judicious with that drug. You want to make sure that we aren't using it too frequently, given that it works really well for some of our really resistant medicines. So with that being said, we have treatment options for multi-drug resistant bacteria. It really varies by the type of pathogen, the location of the infection, the resistance patterns. While new antibiotics treat a variety of infections, it's important to reserve these for difficult to treat pathogens. Infection prevention and antimicrobial stewardship plays a major role in reducing the number of infections that are difficult to treat. And so hopefully that table will really help you in terms of if you have a really drug-resistant infection with some of these enzymes that are identified, that will help you direct your treatment therapy. And so I like to leave this table as the last thing. There are a lot of toxicity with a lot of the different antibiotics that we give. This is not by all means an exhaustive list, but you've probably heard of some of them before, like cefepime-induced neurotoxicity. With fluoroquinolines, there's this risk of aortic aneurysm. Glycopeptides, of course, can cause nephrotoxicity, and it increases when you do it with peptazo combo therapy. And then, so you can go through this and kind of read through these, and I put a couple of key papers here to help with that. All right, thank you so much.